Cardiovascular system. Heart sounds. Heart sounds. S1, mitral and tricuspid valve closure. S2, aortic and pulmonary valve closure. S3, in early diastole during rapid ventricular filling phase associated with increased filling pressures, mitral regurgitation, aortic regurgitation, heart failure, thyrotoxicosis. S4, in late diastole, turbulence caused by blood entering stiffened left ventricle. S3 can be normal in children, young adults, athletes, and pregnancy. Splitting of S2. The second sound of the heart consists of aortic and pulmonic moiety. The first part belongs to aortic valve closure. The second part belongs to pulmonic valve closure. Physiologic splitting of S2. Inspiration, drop intrathoracic pressure, increases venous return, increases right ventricular filling, increases right ventricle stroke volume, increases right ventricle ejection time, delayed closure of pulmonic valve. Wide splitting of S2, seen in conditions that delay right ventricle emptying, pulmonic stenosis, right bundle branch block, cause delayed pulmonic sound, especially on inspiration, an exaggeration of normal splitting. Fixed splitting of S2, heard in atrial septal defect. Atrial septal defect, left to right shunting, increases right atrium and right ventricle volume, delayed pulmonic valve closure, independent of inspiration. Paradoxical splitting of S2, heard in conditions that delay aortic valve closure. Aortic stenosis, left bundle branch block. P2 heard first before A2. In inspiration, we have P2 delay, so it gets closer to A2. So in paradoxical with physiologic condition, in inspiration, normal splitting does not happen. Inspiration, eliminating the split. On the contrary, in expiration, P2 closes earlier. More splitting happens in opposite to physiologic condition. Aortic stenosis. Crescendo, decrescendo, systolic ejection murmur, and soft S2, loudest at heart base, radiates to carotids. Pulsus parvus et tardus. Pulses are weak with a delayed peak. Can lead to syncope, angina, dyspnea on exertion. Mitral tricuspid regurgitation. Holosystolic, high-pitched, blowing murmur. Mitral valve prolapse. Late systolic crescendo murmur with mid-systolic click due to sudden tensing of chordae tendineae as mitral leaflets prolapse into the left atrium. Ventricular septal defect. Holosystolic, harsh sounding murmur, loudest at tricuspid area. Larger VSD has a lower intensity murmur than a smaller VSD. Aortic regurgitation, high pitched blowing early diastolic decrescendo murmur. Wide pulse pressure causes bicuspid aortic valve, endocarditis, aortic root dilation, rheumatic fever. Mitral stenosis follows opening snap. Opening snap due to abrupt halt in leaflet motion in diastole after rapid opening due to fusion at leaflet tip. Left atrial dilation causes atrial fibrillation. Patent ductus arteriosus, continuous machine-like murmur, best heard at left infraclavicular area. Patent ductus arteriosus is often due to congenital rubella or prematurity